post-cholecystectomy. And really what we established is that after cholecystectomy, there's a new baseline for the common bile duct because of that reservoir effect and a little bit of dilation of that duct. So we use that new baseline to determine if there's been an acute change. It's a bit controversial as far as age. There's been this age-old teaching that the common bile duct is 4 millimeters at age 40, and then you add a millimeter for every decade of life after. This has been called into question with more recent literature and larger scale studies on this, which don't show quite that age correlation, but in general, 6 millimeters or less is definitely considered normal. And then beyond that, we just think about if it's an acute change and how dilated it is, and is there intrahepatic ductal dilatation, et cetera. And then sphincter Vodi dysfunction, patients with chronic opiate use, they can also have sort of maybe not normal, but a chronic dilation of the ducts. So first line imaging, we typically start with ultrasound of the gallbladder and ducts, and really reserve CT or MRI or MRCP as second line, depending on what the indication is. And as far as when is this distension or dilation abnormal, of course, the first thing we think of is acute cholecystitis with a very distended gallbladder and dilated bile ducts in the setting of acute choledocholithiasis. We can have more chronic dilation of the bile ducts and pancreatic ducts in the setting of ampullary or pancreatic head mass, and then malignant or benign biliary strictures and choledochal cysts. So I'll jump right into it. This will be a very image-rich lecture so that we drive home these points. This is an example of what our MRCP images look like, and I wanted to show this to talk about what we actually do in an MRCP that is different from a typical MRI of the abdomen. So an MRCP is very heavily T2 weighted, which means that it's a fluid sensitive sequence. So fluid will be bright. And for an MRCP, we do these specific thin sections that are heavily T2 weighted, and then we compile them together. And that sort of helps us get this type of a picture that we call a slab picture on the MRCP, where we can see, similar to a cholangiogram, all the bile ducts, which in this case, for this patient who actually had a liver transplant, we noted diffusely dilated ducts. And in the setting of liver transplant, we're already extremely worried when we see dilated ducts. Our first thing is to make sure the vasculature, in particular, the hepatic artery, looks okay, so that there's not any concern about things like biliary necrosis. I'm not showing those images, but all the transplant vasculature in this patient, including hepatic artery, looked totally normal. But we did see this diffuse dilation of all the intrahepatic ducts in this patient. And then when we go to our thin section MRCP images, we could actually see these two little foci within the at the convergence of the left and right intrahepatic ducts into the common. And those two foci were actually found to be stones. So stones will look low T2, so they will appear as filling defects within the bile ducts on MRCP, and that's what we're looking for to diagnose things like choledocholithiasis. Other things that can also be low T2 are things like air. So pneumobilia will have the same look, but it will be anti-dependent. So in this case, we have sort of two rounded foci that are dependently layering within the, just at the start of that common hepatic duct. So this was in fact choledocholithiasis in the setting of liver transplant, so a bit unusual. And then I'll just call your attention to the fact that everything else on this screen looks dark. So the only thing that's bright in this upper abdomen is the bile ducts. We're not actually seeing much high T2 within the stomach or small bowel to obscure this image, and there's a reason for that. So I'll go into how we optimize our protocols to achieve this type of an image. And then other things that can cause dilation of the ducts are things like gas. So this is a zoomed in ultrasound image where in the expected region of the intrahepatic ducts, we're seeing a lot of these hyperechoic or bright little foci. And it looks branching, like it's going exactly where we expect the ducts to be. And we could see that also in the common bile duct. And in fact, closer to the region of the common bile duct, some of these echogenic foci also have this bright region deep to them, which is what we call dirty shadowing. And when we see that, that's actually characteristic of gas. So we know that these bright foci now are not, they're not stones, they're not intrahepatic calculi, they're actually all just pneumobilia. So this is one thing that can also cause some prominence of the ducts is just having pneumobilia. And in this patient's case, we were trying to get to the bottom of why this person has pneumobilia. And so when we tracked down that common bile duct, which was quite large, as we followed it, we saw another hyperechoic focus there, this time with a different type of shadowing. So this is what we call clean shadowing, and that is more characteristic of calcification. So this was a choledocholithiasis, and presumably this person has been passing stones and essentially had a autosphincterotomy at some point, causing this pneumobilia. They had never had any other sort of surgery or sphincterotomy prior. And just to show how challenging these can be, this is another patient where we saw those little hyperechoic foci within the liver. So at first glance, this kind of looks like our previous case and raises the question of things like pneumobilia, but these do not have that dirty shadowing that I mentioned deep to it. They just look like these isolated little bright dots within the liver. And notice that they're all sort of evenly scattered throughout the liver and very similar in size to each other. So this is, in contrast to pneumobilia, I just show this because this is our most common pitfall, is actually multiple biliary hamartomas or von Meyenberg complexes, which are just tiny little cystic areas, usually less than 5 millimeters in size, scattered throughout the liver. And due to the physics of ultrasound, they can actually act as little specular reflectors. So rather than appearing dark like typical cysts do, these biliary hamartomas will appear actually bright and echogenic like this. And then one of my favorite cases of pneumobilia and dilated ducts here, this was a patient who came in with severe abdominal pain, and this top left image, we can see clear gas within the bile ducts for pneumobilia. And this patient did not have a prior known history of surgery or sphincterotomy. And then as we're looking through in the second image here, we see that not only was the stomach dilated, but much of the small bowel was dilated. And then when we followed that small bowel to the transition point, we actually saw this structure, which was in fact a large gallstone. So this is what gallstone ileus looks like. And this is the classic triad with pneumobilia, small bowel obstruction, and a large gallstone at the transition point. So this is just, a less common reason, but nonetheless, one of the reasons for dilated ducts and pneumobilia. Okay, and then I just wanted to give an overview before we go into the protocols about what these entities look like on different modalities. So on ultrasound, I already showed a case of choledocholithiasis by ultrasound, but this is a different case where we have a dilated common bile duct, and then we see a filling defect that's bright or hyperechoic with all this shadowing deep to it. So this is what we see for choledocholithiasis by ultrasound. Interestingly, note that that same person had a CT quite recent to that, and we don't see this large stone. And that's the pitfall with CTs. It's just lesser sensitivity for gallstones. So for things like choledocholithiasis and cholelithiasis, much better to actually start with ultrasound for that reason. And then this patient actually also ended up having a MRI, MRCP, and on MRI, we know this is a T2 weighted sequence because you can see the bile is bright and all fluid in the stomach is bright, and our internal controls to look at the cerebrospinal fluid in the spinal canal. If that is bright, you're on a T2 weighted sequence. So on the T2 weighted sequence, you can see that there is, once again, the correlate to the ultrasound finding a big duct and then a big low T2 stone sitting there. And here it was not an eye test. We did not need the MRCP in this case, but it does show it beautifully that there is this large stone in the duct. So this is how choledocholithiasis can appear on all different modalities and how tricky it can be on CT. Okay, so we talked about dilated ducts. I'm going to touch a little bit on dilated gallbladder. So this is a patient who had a very distended gallbladder and also had a little bit of gallbladder wall thickening and some pericholecystic stranding, and had a good clinical picture for acute chole as well. So this person was taken to surgery, and based on the CT, we didn't see any radiopaque stones on CT, but as my prior case showed, sometimes that's just a limitation of CT itself and may not be true. But in this case, it was actually a patient with acalculous cholecystitis, and so whether or not it's calculus or acalculous, we sort of see the same other features by imaging of distended gallbladder, gallbladder wall thickening, and a little bit of pericholecystic stranding. And then this is another pitfall case. These are two patients that both came in with right upper quadrant pain. And having seen some of these prior images, I think you may be able to tell what we're looking at here, which is actually that distal common bile duct coming down from porta hepatis towards the pancreatic head. And I'm not showing you a measurement here, but this is a dilated common bile duct. And as we follow it down, we see this intraluminal structure. And we're putting a box on here to look for vascularity by color Doppler, and we don't see anything within that area. And to contrast that, before I tell you what that ended up being, this is our other patient who also had a very similarly dilated duct and with an abrupt cutoff here. And then we see some ill-defined material that also looks like it may be within the duct, and with some questionable little foci of flow in there on color Doppler. And I show this case to show how tricky these can be, because this ended up being choledocholithiasis, and this was cholangiocarcinoma. So these are the pathologies that we look for whenever we try to follow these ducts distally. And like in these cases, if we get lucky, we can actually see that by ultrasound. For most patients, I will say, we won't be able to follow quite as distal because they typically have overlying bowel gas at the midline of the abdomen. So it may require further evaluation by MRI, MRCP in some patients. But for these two patients, we were able to actually figure this out by ultrasound. Okay, and then staying on this theme of dilated ducts, dilated gallbladder, this is a T2 weighted MRI sequence where we did not see any sort of obstructing stone. If there's a stricture at the ampulla, we really wouldn't see anything by imaging typically, unless it's unless there's associated mass or infection. So really, in this case, the only thing we saw was this very, very patulous bile duct in a fairly young patient. And nothing intraluminal and nothing along the wall. So while this could be due to a benign ampullary stricture, this actually ended up being due to a choledochal cyst, specifically a Tadani type 1C choledochal cyst, where we get fusiform dilation of that common bile duct. So that is another pathology that's much better assessed through MRI, because we can actually look at all the intrahepatic ducts carefully on MRCP and on those reformats. And so something like this on ultrasound or even on CT, I think we would be able to maybe come to the same conclusion on CT, but I think on ultrasound can be a little challenging. So for choledochal cysts, I think ideal workup would be to actually go straight to MRI, MRCP. Okay, now on to the imaging algorithm of where to actually start. So for things like cholecystitis, as you know, ultrasound is typically first line. For gallstones, that is sorry. So CT has lesser sensitivity than ultrasound. Sorry about that. And for choledochal lithiasis, mass or stricture, MRI, MRCP has the greater sensitivity. And then for ampullary mass, really any imaging modality is limited. So even if you get a MR enterography, we have not been able to see even 3 centimeter ampullary masses because there are just between the folds and the prominent papilla, it's very challenging to find ampullary masses. So I think that unfortunately even enterography can routinely miss. And then for imaging protocols, so for ultrasound of the gallbladder and ducts, ideally we want them NPO 4 to 6 hours prior. Otherwise, it becomes sort of a postprandial gallbladder that's very contracted, and it's hard for us to tell if it's inflamed or not because postprandial gallbladders are always with a thick wall. And then if there's no analgesics or sedation on board, then we'll check for a sonographic Murphy's sign as well. For a CT, abdomen pelvis with IV contrast, there's no prep required as long as they don't have a iodinated contrast allergy, we should be good to go. And then MRI, MRCP, there's a few considerations. So first thing is to confirm that the patient does not have any MRI unsafe devices or foreign bodies. And this includes some of the MRI unsafe or conditional devices that may be placed by GI or surgery. For example, all the gastric pacemakers that are currently in use are all MRI unsafe. And certain devices like the Lynx device and various other devices are MRI conditional. So we have to be aware of any of those placements prior to protocoling the MRI. The patient should, for these bile duct MRCP exams, they do need to be able to stay still, do breath holds, and if they have any sort of claustrophobia or issues with the noise, then anxiolytic beforehand. And exceedingly rare, but would confirm that they haven't had any prior MRI contrast allergy. And for MRCP, we also have them NPO for 4 to 6 hours prior. And the reason that the image typically looks like the one I showed you earlier, where there's nothing that's bright on the MRCP images other than the bile ducts, is because of these two things. The first is the NPO status, so that there's not a lot of fluid and material in the stomach and proximal small bowel. But the second reason is actually we typically give them 300 cc's of pineapple juice in the MRI scanner 30 minutes prior to the scan. And the high amount of manganese that's in pineapple juice actually causes a T2 shortening effect. So it essentially acts as a negative contrast agent. It'll null everything in their GI tract and make it T2 dark. So that is part of the protocol, just to get that whole area clear so that we can see the ducts properly. And in addition to the typical protocol that we may do for an MRI liver, we do these thin section MRCP images, like I showed you, which are heavily T2 weighted. And then we do not do routine MRCP with secretin. If that is something that you would like us to do, that should be specifically mentioned in the indication. There are certain reasons why secretin, may be used in patients with recurrent acute pancreatitis or sphincter of Oddi dysfunction. It may be useful to see that pancreatic exocrine reserve and to actually see the change, see that secretion into the duodenum with administration of secretin, but that's not something we do on a routine basis. So that is something to specifically request. And then as a side note, while I don't go into post-procedural, post-op in this talk, I do want to mention that if there is a question of bile leak for an MRI MRCP, please do mention that and clamp their drains before they come down, because or otherwise we'll just do that if it's not already been done. But in those cases, it totally changes the contrast that we give. So instead of giving our usual MRI contrast, Gatavist, we'll give a different contrast agent called Eavist, which is not only a vascular contrast agent, but it also will get excreted through the bile ducts and allows us to see the bile ducts and acts like a cholangiogram essentially. But if there are drains that are unclamped, then it'll just preferentially go out those drains and we may miss a small bile leak. So that's something we're always careful about when we image for that reason. Okay, so that was really one of our top reasons that we get imaging is the obstruction and dilation question. But the rest of this talk, I'll just do a quick run through of these other topics. So infection of the gallbladder and ducts, which we see with both cholecystitis, cholangitis, and recurrent pyogenic cholangitis is kind of its own special category. So first, for things like cholecystitis, this is a patient with right upper quadrant pain, where on ultrasound, we see lots of echogenic foci with shadowing within the gallbladder. So it looks like a lot of stones. And then this gallbladder wall was a bit fuzzy. And so there may be some wall thickening. It's hard to tell. This person did actually end up having a CT, and note that we don't see any of those stones on CT. And there was mild wall thickening there. And then look at the drastic difference with the MRI here, where we can see that there's numerous gallstones, same as what we saw in ultrasound, and that, yes, in fact, there is circumferential mild wall thickening. So this was, this patient went to OR and did have acute cholecystitis. There is a new tool that you may see us mentioning in our reports from time to time, which is the cystic artery velocity. And this research was done during my time at Stanford. And it's useful for patients like this, where maybe we have gallstones, we have some mild wall thickening, but the patient is on analgesics or sedation, or we just can't tell if there's any other ancillary features for acute cholecystitis. So for these equivocal cases, we'll check the cystic artery velocity. And in the early literature that we have so far, it looks like a cystic artery velocity of greater than 40 centimeters per second has a 92% positive predictive value for acute cholecystitis. So this patient had a peak systolic velocity of 76. So we mentioned could be acute cholecystitis, and that was confirmed in OR. Okay, and I'll just show a quick image from the literature for another entity, which is recurrent pyogenic cholangitis. So this is a little bit of a different beast here, because instead of seeing, so far I've talked about stones in gallbladder and stones in distal common bile duct. This is an entity where you get typically lots of small stones within the intrahepatic ducts. So for recurrent pyogenic cholangitis, as is shown in this example, we do like to get those same T2 weighted images and get MRCP to look at filling defects. And typically we'll see these dilated intrahepatic ducts with lots of little filling defects on T2. And we will also sometimes see pneumobilia just from the passage of stones in these patients. So those are sort of the the two main things that we look for is just numerous stones and that are intrahepatic, as well as pneumophilia. And that, and then all these stones on these T2 weighted images will be low T2. These can be quite variable on how they look on T1 weighted images, particularly because they can be pigmented stones. And so we really rely only on T2 for much of this evaluation. And then this was a case to show that, you know, even sometimes in the absence of dilation, you can have it be an acute cholecystitis. So this was a patient who had a large gallstone. In this case, we could actually see it on CT. And the gallbladder itself is not very distended, but they have a lot of sort of fuzzy stranding around the gallbladder. So that does look still like an acute cholecystitis. And I show this case because we never want to get satisfaction of search once we find one abnormality. The same patient, a little bit lower down, in the ascending colon, had this asymmetric wall thickening, and which then on scope was found to be a new diagnosis, colon cancer. Okay, and then keeping along this theme of, we talked about cholecystitis already. This is a different patient who came in with right upper quadrant pain and fevers. And we saw this where the common bile duct actually looks like it has an enhancing wall on either side. And on the axial CT images, you see it a little bit better where it looks like a little target sign because we can see the enhancement of that wall so clearly. So typically the common bile duct wall is nearly imperceptible. So we should not see enhancement along that wall. So when we see this enhancement and thickening, it makes us think of ascending cholangitis. And then when we see a long segment of common bile duct, like in this case with thickening and enhancement, it actually points to an even more specific entity. So I'll go into that. But this is a companion case where a patient with similar symptoms ended up having a MRI, and on T2 weighted images, we saw dilated ducts. And then this was a post-contrast T1, and you can see it's very fuzzy. This patient had a lot of trouble with the breath hold, but we did see what we thought was some long segment of enhancement along that distal common bile duct. So since I'm telling you there's enhancement and thickening of the common bile duct, you know, are we worried about cholangiocarcinoma? And in these two cases, no, because it's actually very smooth, it's very long segment, and it's involving the entire common bile duct, and it's not really fitting the clinical picture. So both of these ended up being the same entity. These were both HIV/AIDS cholangiopathy, which can look identical to cholangitis from other etiologies, and can have intra or extrahepatic biliary ductal dilatation or papillary stenosis, but classically has this long segment CBD thickening and enhancement. And I didn't show you this, but on the MRI also had restricted diffusion as well, which is all very pathognomonic. Okay. And then next in sort of the infection category, this was a very challenging case of a patient that some of you may have worked with who had this intermittent abdominal pain, weight loss, had this international trip, had ova and parasites were negative, had upper and lower scopes negative, except for a few eosinophils in the stomach, duodenum, and colon. Presumptively treated for amoebiasis, continued to have abdominal pain, and then 18 months later came to us for an ultrasound. And you'll see that there's some curvilinear, non-shadowing stuff that's within the gallbladder. And then there's heterogeneous masses in the liver. And here is that same area within the gallbladder. And then I'll actually go ahead and show you what it looked like on CT. And in fact, those masses actually got bigger on CT and now looked like maybe they were more fluid filled and they were collections. So IR came to the rescue. That's them sampling one of these collections, and still everything was turning up negative, and even got a repeat upper and lower scope, which was negative. And even a FISH for eosinophilic leukemia, given the eosinophils that were found on the initial scope, and that was also negative. So presumptive treatment was started for Clonorchis and was still not helping. So I'll just show this MRI, and it's T2 weighted, and you could see that there's something in the gallbladder, which initially was called a septate gallbladder, which is a variant you can have. But on the T2 and on these MRCP images, it looks awfully curvilinear, and was there corresponding to that gallbladder ultrasound finding where it was in a different configuration, which gallbladder should just stay the same. So I mentioned this to just remind everyone that yes, indeed, we do see parasitic infections of the biliary tract here. We have seen most of these during my time at ZSFG. And so while this was not Clonorchis on testing, this actually came back positive for Fasciola hepatica. And the patient was treated and all the imaging findings resolved. So all of these can affect the biliary tract. Ascaris is more so small bowel, but can burrow through into the biliary tract as well. Okay, so we talked about some of these infections. So for inflammation, I'll mainly touch on chronic cholecystitis because the various forms of cholangitis are really a lecture unto themselves. So this was a patient who came in for a surveillance scan because of a prior history of adrenal cancer. And this is how the gallbladder looks now, contracted with wall thickening. And this was how the gallbladder looked 3 months prior on their prior scan. Distended, maybe they were just, NPO for too long, but the wall was very normal. So at this point, I was very confused and not sure, you don't just get new onset adenomyomatosis. So this didn't really look like a metastasis. It was too diffuse. So I did what any good radiologist would do, and I punted it to a colleague in ultrasound. And unfortunately, the next time I was on ultrasound, this same patient came through, and we had this gallbladder with lots of gallstones, and then, but the gallbladder itself looked quite postprandial. And I say that because it's so contracted. And the sonographer said this person has postprandial pain since the last exam. And the patient told me that she had been NPO since the previous night. So this should have been a very distended gallbladder, but was very, very contracted instead. So are we worried about gallbladder malignancy? Actually, no, this came back as chronic cholecystitis. And the key imaging feature here is just that it's contracted, even though the patient is NPO and they have this chronic postprandial pain. And then just a word of caution is that we are not good at telling chronic cholecystitis from gallbladder malignancy. And that's why all of these should come out. And in cases where it's thought to be chronic cholecystitis, I think it's always good to keep in mind that malignancy could be identical. This was another patient who had been told that they had gallbladder cancer based on an outside CT. And this was a CT where we see something that looks like gallbladder, has this mucosal hyperenhancement, and we see something else that looks like gallbladder that doesn't have that same type of wall enhancement. And then I think the key here is to see that between those two structures is this little enhancing, what looks like a little bridge connecting the two. So in this case, we're not actually worried about gallbladder malignancy. This is actually segmental chronic cholecystitis of the gallbladder fundus with adenomyomatosis in the gallbladder body. And so you can get this kind of sequestration of part of the gallbladder in the setting of segmental adenomyomatosis, and then get chronic cholecystitis of the part that has stasis. Okay, and then just to wrap up here, talk quickly about some masses and strictures. There's a lot of causes of benign biliary strictures, including stones, cholangitis, pancreatitis, trauma, and then surgeries like all of the ones listed here. And I won't be going into gallbladder polyps and things too much, but just throwing this in there that this is what we use to provide all the recommendations for which ones actually need follow-up is we use these SRU gallbladder polyp consensus guidelines to guide follow-up on these. And when we think about masses actually affecting gallbladder ducts, there's gallbladder primaries, cholangiocarcinomas, and pancreatic. And then this, so this was a case actually that where the gallbladder was very contracted. This patient kind of had this chronic postprandial pain, so it was called as a chronic cholecystitis. And unfortunately, the OR ended up being gallbladder cancer. So these can be very, very tricky and challenging to figure out. Whereas others like this one are a little more straightforward, where we saw what looked like a big mass on ultrasound. It was enhancing on CT, it was enhancing on this post-contrast T1 weighted MRI, and this ended up being a gallbladder adenocarcinoma. But we do have challenging cases like this where we get this sort of cystic, irregular looking gallbladder that goes outside the expected contour of the gallbladder itself. So this begs the question of, is it chronic cholecystitis? Is it cancer? And the truth is, we can't tell because this one ended up being gallbladder cancer with hepatic invasion. And this one ended up being gangrenous cholecystitis with perforation. So these can have a significant overlap on imaging. And then sometimes we see too many branching tubular structures in the liver where, and when we put color Doppler on, we see that they are dilated ducts. And especially if we also see dilated pancreatic duct, we start looking very carefully midline. And in this case, even by ultrasound, we could see an irregular mass that unfortunately ended up being pancreatic adenocarcinoma. And then wrapping up with a few cases here of this patient who had a CT with that showed dilated ducts and then what looked like soft tissue mass centrally. And then you can see on the MRI that right where the ducts converge, we see this homogeneously enhancing mass. So this ended up being a hilar cholangiocarcinoma with invasion along that cystic duct as well, which led to this markedly distended gallbladder. And then this is another one I show just to show how challenging imaging of cholangio can be. So typically for cholangiocarcinoma, we look actually for something like this, where we see on delayed phase imaging, a rim enhancement around a mass for intrahepatic cholangiocarcinoma. But the imaging overlap here is very tricky because rim enhancement and what looks like satellite lesions, you can also see that, you can see that with intrahepatic cholangio, you can see that with HCC, mixed HCC cholangio, or with abscess. So unfortunately, this is a non-specific appearance. And then same thing for when we see solid masses like this in the central liver. It's hard to know when they are so heterogeneous, if it's a HCC or if it's an intrahepatic cholangio. And interestingly, both of these ended up being HCC and not cholangio. So it came as a surprise. And then just for reference, I wanted to show what a classic intrahepatic cholangiocarcinoma looks like and what we look for. These we can tell by contrast enhanced CT. And if you say cholangiocarcinoma in the indication somewhere, then we'll usually add on a delayed phase where it's seen best. So on the delayed phase, we saw some dilated ducts, but then we see this mass that's heterogeneously enhancing, has some rim of enhancement, and it has capsular retraction. So that's all the things that we look for an intrahepatic cholangio, which this was confirmed to be. Okay, so just wrapping up and thinking about gallbladder ducts, I know that was a whirlwind, but thinking about it in these 4 large buckets. So in summary, most of these can be categorized under this infection, inflammation, obstruction, or mass category, which helps us think about how to order imaging and how to diagnose these. And ultrasound is typically a good first line for most of these. And stones are better evaluated on ultrasound than on CT. So not seeing it on CT is actually quite a common occurrence. And if you're specifically concerned about distal ducts or intraductal masses, it's actually better to go straight to MRI, MRCP with all those patient prep considerations we talked about. And then those imaging protocols and limitations can also help you decide if you're between modalities and also can help expedite care for the patient. And these are some of those references. And that is all I had.
All right, thank you so much for that incredible talk, Dr. Raghu. Those are some impressive stones that you showed as well too. At this point, we'll open it up for questions. So if anyone has any questions.